Today we'll be treating patient CH, a 64-year-old Caucasian male whose medical history is within normal limits. His pre-existing conditions do include partially edentulous number 19 and severe periodontitis around 15 and 18. Our treatment plan includes the extraction of number 15 and 18, placement of an implant fixture in the area of 19, followed by restoration using a prefabricated abutment and PFM crown. CH will not be receiving any preoperative medications, and postoperatively he will be prescribed Vicodin. Postoperative care will also include suture removal in approximately 2 weeks. Our restorative plan includes final impressions in 5 months and delivery of his final abutment and PFM crown 1 month after that. And this timeline does coincide with our Implant Institute seminar series. Our surgical plan will begin with profound local anesthesia, the extraction of 15 and 18, followed by degranulation of those sockets, placement of a midcrestal incision in the area of 19, followed by an osteotomy, and placement of the 4.7 by 13 millimeter screw plant fixture. In this preoperative panorex, we can see the extent of horizontal and vertical bone loss in the areas of 15 and 18. It's especially important to note the extent of the radiolucent lesion around number 18. You can see the lesion begins at the mesial, includes the intervertebral bone, and extends well beyond the apex of number 18. We just have to remember to do a very thorough job at removing this granulation tissue prior to placement of our implant fixture. We begin by using the Lucas curette, and we prefer this instrument because it does have directional working ends. Allows us to get 360 degrees around the tooth. Next, we're using our number 17 forceps to further luxate the tooth. And in instances where the tooth is almost completely surrounded by soft tissue, as in this case, it's important to use a pretty significant rotational force to compress the soft tissues that have formed there. We're also using a coronal force that will help us to just lift the tooth directly out of the socket. You can see the granulation tissue that is formed between the roots of number 18. We'll begin by removing that to gain access to the granulation tissue that inevitably is occupying the socket space apical to that. After removal of the bulk of the granulation tissue, we're going to place our midcrestal incision, and that tends to be a bit of a misnomer in our practice. We like to place our midcrestal incision slightly to the lingual, and what this does is it preserves the keratinized tissue on the buccal side, allowing us to manipulate it later to gain optimal soft tissue characteristics as well as optimal emergence profile in our final prosthesis. And you can see there, distal to number 20, that the soft tissue appears to have somewhat of concavity to it, and that is just due to the normal resorption of bone following extraction. So by preserving the keratinized tissue, we'll be able to bulk that out to some degree to give it the illusion that the bone is still there. No vertical releasing incision is needed, and we begin by using the sharp end of the periosteal elevator to begin our blunt dissection. And here we're raising a full thickness flap all the way back to the socket of number 18. Towards the distal, we do encounter some difficulty as there appears to be some granulation tissue still holding the flap against the socket. So it's important to clean this tissue out of there, and we can remove some of it from the surface just using the blunt end of the periosteal elevator to scrape the surface clean. But we definitely want to make sure that as much of this soft tissue is gone. Here we're raising a very small flap on the lingual, and this will allow us to when we finish placing the implant, when we place a cover screw, it minimizes the soft tissue entrapment between the cover screw and the platform of the implant. Here we're just seeing where we want to place our initial osteotomy. So we're lining up the cuss tips and identifying the ideal initial position. We're using a locator drill, and it's important that you use a very sharp-pointed drill for your initial osteotomy, especially in areas where the bone is sloped. And it's just a good habit to use it as your first drill, even when the bone is not sloped. As you progress in your implant surgical skills, you'll want to start placing certain fixtures immediately after extraction. And especially in the maxilla, this becomes very important to use a very sharp drill, pointed drill, so that you don't migrate as you continue to prepare your osteotomy. Migration just refers to the tip of the drill walking as you are drilling. Here we're just ensuring that we have the adequate amount of distance between the adjacent tooth and the center of our osteotomy. Now that we've confirmed that we are in the proper location, we just want to make sure our angulation is good as we begin the osteotomy with our 2mm twist drill. This drill is basically the most important one in the sense that